You're listening to the Turn Autism Around podcast, episode number 181. Today, Kelsey and I are meeting up again to do the top 5 questions about medication, because last week on podcast 180, it was with Dr. Michael Murray. It was a classic rebroadcast, one of our all-time favorite episodes. And that was recorded back in 2019. So we wanted to kind of catch people up with what we've learned within our online community, within social media, about the questions that are still being asked about medication. We wanted to kind of bring it all around. So today we cover all kinds of great things about the top 5 questions. Hope you love it. Here's Kelsey and I discussing medication. Okay, Kelsey, you're back 2 weeks out of this month, but we are going to hop in here and talk all about the top 5 questions regarding medication. I thought it was really good to talk about, since last week on the podcast 180, we rebroadcasted an episode, one of our top episodes ever, with Dr. Michael Murray talking about medications and autism. So I thought we would touch on the big questions we get, just to circle back and talk about medications and some of the questions we've gotten since Dr. Murray originally came on the show a few years ago.
Yeah. And medications are such a big topic in the autism world because, whether it's for, behavior issues, sleep issues, feeding issues, even, like, there might be medication prescribed, and in kids who have especially moderate to severe autism who can't necessarily communicate these things, medication can, like what the side effects might be for them, it can be a really big decision for parents.
Yeah. So let's hear question number 1.
Yeah. So is there a medication for autism?
So the short answer is no. Back when Lucas was diagnosed in 1999, we asked Dr. James Copeland, who we've done a podcast with. We can drop that in the show notes. We asked Dr. Copeland, is there a medication? Because I'm a nurse and my husband's a physician. And so we come from a very medical background. And Dr. Copeland, I remember it clearly, said, we do use medications for kids with autism, but only after a good behavioral program is in place, only after we really see what he's going to do with ABA therapy, applied behavior analysis therapy, which was back then and still is the most proven treatment for children with autism. I know there's some controversy about ABA, and I did a podcast on the 4 myths and truths about ABA from my perspective. We can link that in the show notes as well. So, and then the other thing Dr. Copeland said, and again, this was years ago, was that there's not a specific medication for autism. There's medication that treats symptoms that some kids with autism face, like there's medications for sleep, there's medications for aggression, there's medications for anxiety or depression. There's medications for obsessive compulsive behavior and those sorts of things. So unless you know what you're treating, which the only way you can really know what symptom you're treating is by doing an assessment and doing a plan and trying to teach without medication to get a baseline. Like, we need to really think about, first, we have to do all of the things that I preach every single day, and you do too, Kelsey. So no, there's not a specific medication for autism. There are some that are more commonly used, like risperidol and Abilify are 2 of the top ones that I've seen prescribed. But it's that's kind of my answer. I don't know if you have anything to add.
Yeah, I mean, that would be the same thing I would add. I know a lot of kids who end up getting prescribed ADHD medication, or again, anti-anxiety medication like Prozac or fluoxetine type stuff. And then there's medication, like you said, which is technically an antipsychotic, which is risperidone and Abilify. And a lot of the times we see those given to kids who have high problem behaviors. But there's not a lot of, it's so tricky because, again, like you said, Mary, it so much depends on what you're trying to treat. And at the end of the day, if a child's aggression is helped by medication, you may be able to teach more, which then can help their autism and their symptoms of autism. And if, they're not learning because they have such high symptoms of ADHD, it can help that way. But like you said, having a good behavioral program in place and having other good supports in place is really how you're going to help medication work to its fullest extent.
Right. Like even 2 episodes ago, on episode 179, we talked about sleep and how, like melatonin might be used, but it might, if you're not taking some kind of data, like calendar data, it may actually backfire and do the wrong things. I know for Lucas a lot, we probably tried 12 medications when he was younger. And I had no record. I didn't know how old he was, what we were treating, what the dosage was, why we got off of it, what side effects were. I mean, I have no idea because I did not have my calendar system, which I am a big fan of. So basically the calendar system is you get a physical calendar, not an electronic one. In the front of ours, we usually have a pencil and a red pen. And the pencil is used for staffing changes or those sorts of things for his therapy. And then the red pen is used for any kind of medical issue. Sometimes kids with sleep problems, we can put that in there. Allergy shots do, antibiotics, and behavioral issues. So unless you're really keeping track of things, I think throwing medication on a situation can make it actually worse in many cases and can backfire.
Yeah. And that brings us to our next question, which is my child's doctor or teacher is recommending medication. How do I know if it is right?
Okay, so I first want to say that teachers, and if you're a teacher out there, teachers should not be recommending medication. As you could tell from Kelsey and I talking already in the first few minutes, is that it's extremely complicated. Even as a registered nurse or as a physician, you don't want to throw medications on a child, especially a child that can't communicate side effects, how they're feeling. They might really have a reaction to weight gain or to some side effect that you end up feeling like you're chasing your tail, or you're treating this, but this is getting worse, or this doesn't seem to be helping. But if you're not keeping any data and you don't have any behavioral process in place, it's probably not going to work. So teachers, I would really not be recommending medications. And then, regular pediatricians could recommend it. I would really look for a provider who has expertise working with kids with autism, if at all possible. I know child psychiatrists are very hard to come by. And then we do have to rule out other medical issues like PANS, pediatric autoimmune neuropsychiatric syndrome, which we have a podcast on. We can link that. We have to rule out things like allergies. In last week's episode, we talked about Lucas's autonomic nervous system dysfunction, which is like that fight or flight reaction. So he would get, if he got startled or was in pain, he would have aggression. So, in the past, when he's had aggression or self-injurious behavior, when it was at its worst, and he was really hitting his own head hard, the behavior analyst was like, well, maybe he needs a helmet and that sort of thing. But I knew as a nurse and a behavior analyst as well, that this was happening, sporadically. In the middle of the night, he'd wake up screaming in pain. He would get startled. Like, I'm not going to put a helmet on a child who is having this episode once a week or once a month, and it's clearly linked to something that's happening. But I had to go to multiple doctors till Dr. Murray figured it out. So even if you have a doctor who is recommending medication, I still would be a little bit hesitant unless I had a really good behavioral program in place and I had at least calendar data to show and had a symptom that I wanted to try to treat.
Yeah. And I totally agree with you, Mary. I think the symptom you want to treat is the big factor for me, and your assessments, because, but I mean, I've talked about it lots. Brentley had a lot of self-injury, and every doctor we went to wanted him on some type of medication. It wasn't until he was in a real crisis situation that I agreed to try something. And what they eventually talked me into trying, and the reason why, was clonidine, because it was something that had like a really low side effects, since Brentley couldn't really tell me what was going on. But I remember I gave it to him, and it's technically a sleep medication, but sometimes it's used at low doses all day long to kind of mellow kids out who might have this irritability. And he would sleep all day. I have pictures of him falling asleep on a dock at a beach. Just like he would just fall asleep randomly, which he had never done everywhere. And I was like, this is not a life. Like, well, so I stopped that. And then I went back to the drawing board and kind of with my behavior analyst looked and was like, okay, so he's banging his head. When is he banging his head? And it goes back to the drawing board of how do we prevent these behaviors? What skills do we need to teach? And when we start teaching these skills, is there something in his behavior that's preventing us from teaching those skills that maybe we could look into a medication for? And so again, that's where I would go with that. What specifically do you need help with to help teach these other skills? Because it's just, especially in a child like Brentley, who it is larger already and is prone to weight gain, like to put him on what's probably the most research for his issues at the time would have caused a lot more weight gain, and no one else seemed concerned about that. So I think as a parent, it's just really important to trust the doctors, but also to do some of your own research on the side effects and what you know about your child, because doctors are there to help you. And when you go in saying, I have this issue, this issue, this issue, they're probably more prone to just look at the medication route. Whereas a parent, sometimes we need to look at the whole picture with our behavior analyst, with the doctor, with the OT, with the SLP, and kind of figure out what option is going to be the best. Because they started trying, I talked in their sleep episode about Lincoln's night terrors, and because he wasn't sleeping, he was having crazy behaviors during the day, and he was just 2 years old. They started trying to prescribe him antipsychotics at under 2 years of age, which I did my research. I realized, well, our sleep is the issue. Let's tackle sleep and let's see if his behavior gets better. And it did immediately. Once we gave him, fixed his iron issues and he was sleeping, the behaviors went down. And so again, you just really trust doctors, but also look at the whole picture before, throwing medication onto things.
Right. And we're also saying that sometimes, like Interroll, which is a cardiac med, a beta blocker, as you heard from last episode, if you listen to 180 with Dr. Murray, I mean, I got there, I was like, he's having self-injurious or aggression and aggression for being startled, for having pain. Like, that is it. I have calendar data I can show you, like he's having it once a week or once every 2 weeks, or sometimes in the middle of the night. And when he said, okay, I think I know what's going on, I was like, wait, really? Like, because I have literally been across state lines to doctors to try to help me figure this out. I mean, this went on from age 14 to age 18, where I was really worried. And then he's like, it's an autonomic nervous system dysfunction. And I'm like, a fight or flight reaction. And I'm like, okay, that makes sense. Like, what do you do for it? And he's like, oh, we use a beta blocker. I'm like, really? There's a medicine for this? Like, not an antipsychotic. And not that I'm against antipsychotic. No. It's just, I knew that would just be throwing a Band-Aid on something that was happening so sporadically that related to something else. And so, I think we're both saying the same thing. It's like, we're not anti-medication,
No.
but just make sure you have your ducks in a row so that you're not making things worse.
Yeah, and once you add the medication, taking data, whether and that your data might be great and that's wonderful. But if you're seeing, okay, this is getting better, but this is getting worse, looking at your priorities and seeing what, if that's working for you or your child, and that's where the calendar data comes in.
Yep.
And that brings us to our next question: how do I know if a medication is working?
Yeah. So you need good baseline data. You need the goal for a medication. What symptom are you trying? And then you need ongoing data, calendar data, ABC data, rate data, whatever whatever you have the capacity for, whatever you have baseline on, you want to continue taking data, at least in the beginning. And then you might need to go up on the dosage. You might need to double the dosage. You might need to taper off. Not every medication that you try can you just pull out. Some medications are actually dangerous to just stop. So you might have to work with the doctor to taper them down. You might try this, but it's not working. Even with Interroll, which was literally like saved Lucas's life, because it was 4 times a day, that was a pain, right? And he was at school and he couldn't go into the community with his aide or with the school because nobody could administer the med. So we tried long-acting Interroll. So I was like all for it, right? We'll just do it in a capsule, and it didn't work. So the Interroll 4 times a day was working great. We tried Interroll long-acting, and it was like worse than before. Worse than if he wasn't even on it. And so again, I'm like pulling out my hair, taking data, calling the doctor, and we tried long-acting Interroll like 2 or 3 times during the day, and it just backfired each time. And I was just like, okay, forget it. We're just going back to what we know works. Which brings up another point, and we talked about this last episode with Dr. Murray, is we did a swab test that he recommended when Lucas was 18. We did it through genomind.com. We can link that in the show notes. And it's a swab test. And it basically takes the DNA of the person that you're doing the swab on, and it runs medication through it. So it sees what's compatible, and it gives you a report: green meds, yellow meds, red meds. So red are medications that will most likely cause side effects, because his DNA does not interact well with it. Yellow meds it'll probably work, but there might be some issues. And green is good. So for Lucas, all of the newer antipsychotics like risperidol and Abilify, those were all in the red. And all the older antipsychotics like Haldol and lithium were in the green. Interestingly, Interroll was in the yellow, the drug that really has saved his life. And it also said there that he's a very rapid metabolizer of Interroll, which makes sense of why the long-acting didn't work. He needs high doses of it, and he needs a steady supply. And the other drug that was ordered as needed was Valium, just for his outbursts. Before we knew he had an autonomic nervous system dysfunction. We hardly used it, but that was in the red. But Ativan, which is very similar to Valium, was in the green. So just to give a little bit of context, if you have a child or client who is on multiple medication, or on a medication and it's not working, or if you can get this paid for, Lucas is on medical assistance in Pennsylvania, which pays for it. So it wasn't a problem, but depending on your insurance, it might be pretty pricey. And if you have a child with psych issues, say they're not autistic and they don't have special insurance, sometimes you have to trial a few different psych meds and have failed before they will allow this test. I think everybody should have it, because now that we have Lucas's test, if he developed seizures or he needed a cardiac med for cardiac health, like we could look on the list and see which meds would be good to try, or if he needed an antipsychotic in the future. even pain meds. It's all meds for all people. And so really, really valuable. And I would just really encourage people to look into it. There are a couple companies that do it. Genomind is one, and GeneSight, I think, is another.
Yeah. Yeah, it's definitely a good thing to do. And yeah, just watching the side effects, and if you have a child who can communicate, obviously asking them how they feel, or trusting them if they say something hurts when they're on the medication. And yeah, talking to teachers and everyone in their life to see. I know some families I've worked with don't tell the teachers when they start medication, to see if they have an unbiased opinion on if things are working. I'm not suggesting to do that, but that's one thing to do as well.
Yeah.
Yeah. The next one is, can supplements help before trying a medication?
So I did a video blog, and it's something like, are supplements all bad and medication all good, and vice versa? If you come from a traditional medical model, usually, even behavior analysts, I've posted some research and things on more supplements or zinc to copper ratio and those sorts of things. And behavior analysts have like privately messaged me, like, how dare you, like, that's pseudoscience. I'm like, what? Like, the use of zinc and magnesium is not pseudoscience. I mean, I don't claim to be an expert in this area, but all supplements aren't good or bad, and all medications aren't good or bad. I give, in that blog, I give the example of Lucas having getting agitated after multivitamin administration, and it was due, I think, to the copper in the multivite. And he did have a low copper to zinc ratio, and so we've been supplementing with zinc for years. So yes, you can try supplements, but I would do it with a practitioner. We do have a podcast with a functional medicine nutritionist, Denise Foyt. We also have a podcast with a behavior analyst, and where we talk about zinc quite a bit, Melissa Olive. We can link those in the show notes. But just being open to, whatever's going to be healthiest for your child in terms of nutrition and health. And it's not all figured out yet. I think within each child, within Brantley and Lincoln and Lucas, there's like a bunch of levers, and some need to go up and some need to go down, and that may change as they grow, as they hit puberty. All kinds of things can happen. So the more you can just stay calm and try to figure it out as the captain of the ship. That's the role of the parent.
It just comes back to me for data. If you're more comfortable as a parent starting with supplements, try it and take some data. Work with a functional medicine doctor, blood tests, stool samples. They can help guide you. Brentley is still on a migraine protocol given actually by a traditional medical doctor, neurologist actually, of supplements like magnesium B2, I believe, and we had to mess with dosages, but yeah, different supplements have helped him to prevent migraines. And then, a lot of people say, fish oil can help young kids with autism. We gave him that, and he gets like bright red cheeks, like a histamine reaction, and doesn't like that. So it's all about every kid looking at different reactions, and if it helps or if it does anything. But yeah, same thing. So our last question about medication is, my child won't take medication. What can I do?
Yeah, so supplements, medication, it's a challenge, especially with kids who are picky eaters and who are very, don't like the taste of certain things. Lucas never liked juice, and I think that's actually fine, because one of the things I do not recommend is dumping stuff in juice, and then the child's walking around all day with the juice and the sedentary stuff on the bottom, and it's just that's not the way you give, like if this is a real medication, or even if it's a supplement, you're still paying for it. You're still trying to see if it works or not. You don't know if, unless it's in their mouth and down their stomach, if it's going to work. So I do have a video blog on the importance of ruling out medical issues. I have a video blog on how to get kids to take medicine. I mean, it's a shaping process, just like everything else. Lucas, I used to crush pills and put it in applesauce and then spoon it in with a strong reinforcer. Then he needed to go on the 21 days of steroids when he had his PANS and his tic disorder. And so the doctor said that prednisone crushed up would taste really nasty. So he's like, why don't you just dunk it in the applesauce and have him swallow it? So now he actually gets out the applesauce, gets out his pills, takes big capsules, dunks it in the applesauce and eats it whenever he needs medication. So for him, that's his medication. That's the way he takes it. So for other kids, I would do the same. I would, if you can get them to just put it on their tongue and take a gulp, that would be better. Because it's kind of sometimes a pain when Lucas needs medicine and we don't have applesauce, or, it's kind of like we're running around. But in general, we want to just start with something very small, like a little piece of pasta or one little piece of rice. Get them to stick it on their tongue or even dunk it in applesauce. And then as you can get bigger, you can use things like beans, split peas in a bag. So we can gradually increase the size of these fake pills. And some people recommend like Tic Tacs and stuff, but they have a taste. Kids might chew them, kids might like them. So I would pick something bland like rice and beans and orzo, pastas, things that aren't going to be harmful for your child to swallow, and then increase the size as you go, whether it's dunked in applesauce or whether it is taken with a pill. Sometimes video modeling, sometimes sitting side by side and you doing it first, sometimes having a sibling model it. These are just some of the ways you can get kids to take pills.
Yeah. I agree with everything you said, and yeah, I taught both boys when they were on iron to swallow, because liquid iron can be really bad for their teeth, and also my boys never drank a lot of juice. I actually find it much harder to get liquid medication in a child than teaching them to swallow pills, because that's often you don't have a taste, and it's fun to be like, it's in my mouth, it's gone, it's gone, like that's funny. So yeah.
Yeah. Okay. Well, hopefully that was helpful to some of you out there listening. If you didn't ever watch the podcast interview last week, 180, you're going to want to check that out with Dr. Michael Murray. But hopefully this was helpful. Our top 5 questions. And if it was, we'd love a quick review on Apple Podcasts or wherever you're listening. And we'll see you right here next week.